If you live in a high-income country, believe in science, and more or less trust your government, then chances are you're already fully vaccinated, and so are most people around you. You may even be thinking about getting that third dose or the booster dose already. If you think that that's also the case for most places in the world, sorry, unfortunately, that's far from the reality. The fact is, as of today, according to UNDP's Global Dashboard for Vaccine Equity, the latest statistics show that 62.79% of the population in high-income countries have been vaccinated with at least one dose as of October 20th, 2021, whereas only 4.51% of people in low-income countries have been vaccinated with at least one dose. Just 2 months ago, the numbers were at 57.4% and 2.14 respectively, illustrating the huge discrepancy between high-income countries and low-income countries in terms of access to vaccination. And depending on which sources you're looking at, One World in Data reports only 3% of people in low-income countries having received at least one dose of the COVID-19 vaccine as of today. On UNDP's Global Dashboard for Vaccine Equity, you can also see which countries have procured the highest number of vaccine doses for adults and which countries have destroyed the highest number of doses. All these data show us that there's a huge discrepancy in vaccine rollout between rich and poor countries. Here's a summary of the situation on the global dashboard. A slower and delayed vaccination rollout in low and middle income countries have left them vulnerable to COVID-19 variants, new surges of the virus, and a slower recovery out of the crisis. High-income countries started vaccination on average 2 months earlier than low-income countries, and access to vaccines in low-income countries is still strikingly low. So how do we explain this vaccine inequity? Factor number one, global wealth inequality. One thing we can see from the previous data is that vaccine inequity is highly correlated with the global wealth inequality, and global wealth inequality is deeply rooted in colonialism. The idea of the lack of vaccine equity as an extension of new colonial relationship was brought up by Dr. Kojal Sena at a panel on What COVID Vaccines Reveal, Myth and Reality of Post-Colonial Global Health, organized by NYU School of Public Health in April. And I quote, "Why is there such an eagerness to test the vaccine in poor countries, but then when it comes to vaccine rollout, we aren't willing to give access?" Scholars from University of London, LSE, and Harvard also believe that vaccine apartheid has its roots in colonialism and exists and persists today because of new neocolonial forms of power. And only a reparative vaccine justice movement can overturn this colonial legacy. I highly recommend the article Global Vaccine Equity Demands Reparative Justice, Not Charity by Sophie Harman et al. By the way, all the articles and resources cited or mentioned in this short course can be found in the list of references that I share at the end of the course. Factor number two, vaccine nationalism. Vaccine nationalism is the mentality of state leaders that each nation should take care of its own citizens first, and that leads to vaccine hoarding by rich countries in the early months of the vaccine rollout. Governments of high-income countries that have invested billions of dollars in the vaccine technology would, of course, want to secure as many doses as possible for their own people. If you want to learn more about the earlier bilateral deals between governments and pharmaceutical companies and the implications of these deals on vaccine distribution, check out the 8-minute-long video by Vox titled "How Rich Countries Are Making the Pandemic Last Longer." The video also explains why the formation of COVAX, the global initiative by WHO and two other global health organizations aiming at accelerating the development and distribution of COVID-19 vaccines to middle and low income countries, has not been very successful in curbing vaccine nationalism, which I'm not going to go into details, but if you're interested in learning more, definitely check out the video. Factor number 3, vaccine monopoly. The People's Vaccine Alliance says that the cost of vaccinating the world against COVID-19 could be at least 5 times cheaper if pharmaceutical companies weren't profiteering from the monopolies on COVID-19 vaccines. On the same NYU panel that I mentioned earlier, Dr. Matthew Kavanagh pointed out that pharmaceutical companies have been reluctant to waive the intellectual patents and continue to monopolize vaccine production and distribution. And I quote, the idea that somehow the fact that the United States, because it had the funding to be able to put into the NIH to be able to create the vaccines, should then somehow exercise the monopoly over how those vaccines are produced, who gets them, etc. I mean, what's remarkable right now is actually, I can't think of a time in history where we've done this kind of level of allowing a handful of private sector actors to determine our ethical allocations, and I think it's a huge problem. End of quote. And because of Big Pharma's monopoly on COVID-19 vaccines, some governments, such as Colombia and Thailand, are charged a premium way above the estimated cost of production. Moderna, for example, has been denounced recently in a New York Times article titled Moderna Racing for Profits Keeps COVID Vaccine Out of Reach of Poor. The company is accused of putting a priority on wealthier Western countries, making middle and low income countries pay more and wait longer. My own network in Thailand confirmed that they had paid 3,800 baht, which is about 114 US dollars, to reserve Moderna vaccines a few months back, and they're still not getting them at the time of this recording. Factor number 4, deployment challenges. Many low-income countries and rural areas lack the infrastructure necessary to distribute and administer the vaccines. As pointed out in the article, COVID-19 Vaccine Equity and Booster Doses in The Lancet, one of the world's oldest and most reputable independent medical journals, getting vaccines to low and middle income countries requires an uninterrupted cold chain. In other words, temperature controlled environments to transport, manage, and store the vaccines. This is the case in Africa and a lot of places in Asia, where many communities live without continuous power supplies, and freezers that cost up to 20,000 US dollars are simply unaffordable. This is true for vector vaccines such as AstraZeneca, J&J, and Sinovac, and not to mention the vaccines made with the mRNA technology that require sub-zero temperatures to preserve. Factor number 5. To fully account for vaccine inequity, we need to address what we call vaccine hesitancy. In an article in the WebMD News, it is reported that in the US, African Americans have nearly the lowest rates of vaccination among any ethnic group. In fact, white Americans are being vaccinated at a rate 3 times higher than Black Americans. New CDC figures show that of those who have received at least the first dose of a vaccine, 5.4% are Black people compared to 60% who are white people. To understand vaccine hesitancy in the Black American community, we can't not quote Dorothy Roberts, JD, who says in the same article, "It is not that Black people have an irrational fear of new medical technologies. It is that they have an awareness of a long history of being disrespected, mistreated, and violated by the government and by healthcare professionals." And she continues to say, "It's not just that there was a past history of medical experimentation on Black people that makes them suspicious of new technologies today. there is a continuing practice of racism in medicine and government policies that many Black people have experienced themselves. That's why there's this skepticism about the government rollout of the vaccine. It is a rational skepticism, and the only way to address it is to work towards ending the racism in medicine and healthcare that caused the skepticism in the first place. I cannot say it more eloquently than Dr. Roberts. It's so true that this mistrust is deeply rooted in centuries of systemic racism on all levels. And to be able to build trust again, we cannot look away as if racism was a separate issue. Of course, vaccine hesitancy is not just an American issue, it is a global issue. Vaccine hesitancy in sub-Saharan Africa also poses challenge to the fight against COVID-19 in that region. As a blog post of the World Bank summarized, access to social media in the sub-Saharan African region has facilitated the spread of misinformation and conspiracy theories. The African CDC study has found a correlation between the level of hesitancy and the use of social media, hence exposure to disinformation. There is also a general distrust of Western medicine due to the history of unethical Western medical practices on the continent. In some countries, religious beliefs are also a factor for vaccine hesitancy or anti-vaccination. Now, vaccine hesitancy isn't just an issue among historically oppressed racial groups. In Hong Kong, a large percentage of the population had been resisting the vaccines not because they do not believe in science, but because of the deep distrust in the Hong Kong and Chinese governments. Quoting an article in First Draft News, COVID-19 and the vaccines against it came after a year-long pro-democracy protests in 2019 and a sweeping national security law that China imposed on the city the following year. A lack of confidence in the government to act in the people's interest during that turmoil was reflected in online discourse about the vaccines, especially the Sinovac shots. To sum up, the current global vaccine inequity is caused by many factors, and they take place at various stages from the development and production of the vaccines to their affordability, allocation, and deployment. As less than 5% of people in low-income countries have been vaccinated with at least one dose, according to the data we saw earlier. Now, everyone in high-income countries is talking about the third dose or the booster dose. In fact, a third dose of the mRNA vaccines is actually identical to the first two doses. It is recommended for people with compromised immune systems to help further protect them from getting severely ill or dying due to COVID-19. But if you are healthy, below 65 years old, and are fully vaccinated with two doses already, chances are that the vaccines you have already had would give you adequate protection for at least a good while. According to an article in The Lancet, the administration of a third dose is motivated by fear of the Delta variant, but the intensity of this fear is unfounded, as there is now evidence that vaccines licensed in high-income countries are effective enough against it. Conversely, there is no evidence if and when a third dose is necessary. Given this context, should high-income countries prioritize sending vaccines to low-income countries first and let their people have their third dose later? In the New York University panel on vaccines and global health, Dr. Matthew Liao brought up the distinction between urgency versus need. He said, "We all need the vaccines, but it's more urgent for some of us than others. So some people believe it is reasonable to prioritize urgent cases around the world as soon as possible." You may now say, okay, now I understand what vaccine equity is, but what does that have to do with us, the travelers? The answer is very simple. No one is safe until everyone is safe. Every organization, um, humanitarian organizations or organizations that are fighting for vaccine equity, keep repeating this line because it is true. Not paying attention to vaccine equity is only going to prolong the pandemic and the road to recovery for the travel industry and for all other industries that have been suffering. If we want to be able to travel like how we used to be, let's first make sure everyone in the world has the protection that we have against the coronavirus. Coming up, we're going to talk about the risks of traveling right now and implications of the lack of vaccine equity on travel destinations. I'll see you in the next video.